Dr. Kalyan, just identify yourself. I'll make you the co-host. Dr. Padmini, there are two IDs.
Sir, my audio in system has some problem. That's the reason I have logged in through my mobile also for audio purpose, sir.
Okay, sir. That's fine. I'm just worried if you just continue the way it is now. No changes. Dr. Kalyan Verma, ఒకసారి respond అవ్వండి. భాస్కర్ సార్ ఇందాక వచ్చారా ఆయన? ఒకసారి కాల్ చేస్తాను. నేను ఒకసారి చెప్తాను.
జయరావు గారు, మీ దగ్గర ఎన్ని డిఎన్బి సీట్స్ ఉన్నాయండి? పీడియాట్రిక్స్
ఎండి ఉన్నాయి అక్కడ భాస్కర్.
మల్లారెడ్డిలో
మా దగ్గర ఎండి ఉన్నాయి.
అదో ఎండి కదా, సారీ.
8 ఎవ్రీ ఇయర్ 8 సీట్స్ ఎప్పటి నుంచి ఉన్నాయి. ఇప్పుడు ఎగ్జామ్ గోయింగ్ బ్యాచ్ ఉంది ఇప్పుడు మాకు.
ఓహో, 8 అంటే బాగున్నాయండి. 8 ఎండి సీట్స్. డిసిహెచ్ అండి?
రంగనాథ్ ఉన్నప్పటి నుంచి ఉన్నాయి.
డిసిహెచ్ అండి?
డిసిహెచ్ ఇప్పుడు లేవు కదా అసలు,
తీసేసారా?
ఆల్మోస్ట్ లైక్ ఎండి, ఆల్ ఎండీస్ హావ్ బీన్ కన్వర్టెడ్ ఇంటూ డిసిహెచ్. అండ్ జనరల్ గా ఇప్పుడు అసలు ఎవరు కూడా అప్లై చేయట్లేదు, ఆల్మోస్ట్ లేనట్టే. అయితే నేషనల్ బోర్డ్ హ్యాస్ స్టార్టెడ్ వన్ కోర్స్.
వాట్ ఇస్ దట్?
పోస్ట్ ఎంబీబీఎస్ Diploma in Child Health within brackets National Board of Examination. They have started. Dr. Kalyana?
Yes, sir. Good morning, sir.
Kalyan, బాగున్నారా?
బాగున్నాను సార్. సారీ సార్.
నేను ఇంకెవరో అనుకుంటున్నానయ్యా. నేను కళ్యాణ్ అంటే ఎవరా? కళ్యాణ్ వర్మ. గుడ్ గుడ్. కళ్యాణ్
సార్,
అదే నేను మామూలుగా పెట్టాను కానీ let us not restrict ourselves. As and when we have a point to make, because you are basically you are a young teacher, I thought you better you take care of that, but it doesn't mean that we are restricting ourselves. As and when situation demands, we'll have to stop and question the postgraduate, right?
Okay, sir.
Right. Now you are in Bachpalli.
Yes, sir. Bachpalli, sir. Mamata, sir.
Bachpalli DNB అని ఉన్నాయి అక్కడ? ఏం లేదు.
లేవు సార్. నెక్స్ట్ ఇయర్ పీజీ వస్తాయి సార్.
అంటే ఫస్ట్ బ్యాచ్ పాస్ అవుట్ అయిపోయిందా?
అవ్వలేదు సార్. ఇప్పుడు థర్డ్ ఇయర్ కంప్లీట్ అయింది సార్.
అయినా అప్లై చేయొచ్చట?
అప్లై చేయొచ్చు సార్. 3 years అయిన తర్వాత అప్లై చేయొచ్చు సార్.
ఓకే.
భాస్కర్ సార్, ప్యాట్స్ ప్రెసిడెంట్ వస్తా అన్నారు కదా, ఒక 1 minute వెయిట్ చేయమంటారా?
ఫోన్ చేయొచ్చు సార్.
ఒకసారి ఫోన్ చేయండి.
హలో సార్.
విజయ్ గారు ఎక్కడున్నారు?
నేను కరీంనగర్ లో ఉన్నా సార్. అది లింక్ వచ్చిందా సార్ నాకు?
Subramanian sir, welcome and
Sir, good morning, sir.
yeah, good morning, Vijay.
హాయ్ విజయ్,
Good morning, sir.
ఏంటి వరంగా కరీంనగర్ ఎందుకు వెళ్ళావయ్యా?
ఇది ఈసీడీ వర్క్ షాప్ ఉంది సార్.
ఆహా.
ఎన్సిఈసిడి వర్క్ షాప్ కరీంనగర్ లో ఉంది సార్.
ఓ, ఏదో బిజీ ఉంటున్నావు నువ్వు సండేస్ కూడా.
Yes, sir.
సండేస్ అన్ని బుక్ డే సార్ ఇప్పుడు.
యావత్ తెలంగాణ ఈసీడీ ఎన్టీఈపీ మొత్తం ఎడ్యుకేట్ చేస్తున్నానండి.
వెరీ గుడ్.
Bhaskar sir, shall we start?
ఎందుకు
Yeah, the setting will be such that only co-host can speak. If there's anyone else who needs to be made the co-host, please raise your hand anytime.
డాక్టర్ విజయ్ కుమార్ కూడా కోర్స్ చేయండి.
చేశాను సార్, చేశాను. Good morning, everyone. Namaskaram and welcome to today's webinar. Today's webinar is IAP Twin Cities branch postgraduate clinics. Postgraduate, it's always a very scary, very exciting moment for us when we face external examiners. And very rarely in our tenure as postgraduates do we get the chance that we get to interact with professors and examiners who are not really with us over the past 3 years. And IAP Twin Cities has committed to ensuring academics at the forefront and sharing the wisdom and the experience of a lot of experienced teachers with the postgraduates. And I'm sure these experiences will help you when you finally take your final exams. We have a wonderful panel today of Dr. J.V. Rao sir, my teacher and someone whom I have worked with in the early stages of my career at UNICEF. Thank you, J.V. Rao sir, for accepting and being part of today's PG Clinics. And also Dr. Kalyan Verma, a young and upcoming teacher at Mamta Institute of Medical Sciences. So it's a good balance of experience and also the wisdom of the recent updates. So I'm sure the presenter will have very good experience in presenting this case. I request all the people who have logged in to share your comments in the chat box. It's going to be very interactive. We'll pause multiple times and ensure good discussions on aspects which are related to this particular case. So please feel free to type in your comments, thoughts, queries in the chat box. I also share this moment to invite you all for IAP Twin Cities. I share this moment to invite you all for IAP Central Zone Pedicon 2022, which is from 1st to 3rd of July 2022. Request you all to please register and be a part of the 5 states conference, and I promise you a 5-star experience with all your support and active participation. I now invite our President, Dr. Sunkoj Bhaskar, to give his inaugural remarks.
Thank you, Dr. RSV. Thank you. Respected President, Dr. Arakalla Bhaskar, I hope he's there, otherwise in absentia. The seniors, particularly Dr. G.V. Subramanian sir, and our esteemed faculty, Professor Dr. J.V. Rao, Dr. Kalyan Verma, Dr. Vijay Kumar, Professor Dr. Vijay Kumar, Dr. Padmini, Associate Professor, dear participants, ladies and gentlemen, I sincerely welcome you all to this 5th IAP TCB monthly PG Clinics. I'm very happy that we didn't miss even a single IAP PG Clinics during the last 5 months, because our EB had taken it very sincerely and seriously to conduct PG Clinics, because it helps a lot, particularly postgraduates and practicing pediatricians, more so during COVID period, We had an excellent academic activities. The same thing which we are continuing. I'm sure it's going to be very, very helpful to postgraduates, because after all, this is exclusively meant for PGs to improve their clinical knowledge and skills and how to approach to the case. That is more important than final diagnosis and management. First time we had invited the second largest branch in Telangana state, that is Warangal state, Warangal branch, to have a case from Warangal, MGM Hospital Warangal. It expresses our solidarity and support to other branches as an elder and largest branch of Telangana state. In this regard, I am thankful to Dr. G. Vijay Kumar for providing us a long case and organizing case to us with the help of Dr. Padmini and as well Dr. Priyanka. And my special thanks goes to Dr. J. V. Rao sir, despite his busy schedules and family activities on Sunday, he is very active in academic activities, as well in NNF, and also HOD at Mallareddy Medical College. With the 8 PGs which I came to know just now, they are very lucky to have a teacher like him. Just now, if anybody had there initially, he had just simply encouraged the presenter, saying that don't worry, Amma, your second year will take care of you. Those friendly words are enough to push the morals of postgraduates. That is the wisdom of our Dr. J. V. Rao. And as well, thanks to our Dr. Padmini for mentoring the case. And today I feel and I think the luckiest person of this symposium would be none other than presenter Dr. Priyanka. And this time we had chosen one talented speaker, young pediatrician, who is none other than Dr. Kalyan Verma. Our intention was to promote the hidden talent from the upcoming batches, particularly from the younger academicians. So to set an example, we had invited Dr. Kalyan Verma and he had readily accepted. Thank you, Dr. Kalyan. For this, I am thankful to Dr. RSV, who had instantaneously suggested your name and you had accepted instantaneously. And as well, thanks to Dr. Yashwant Rao, again, who had really recommended your name to me. So I am sure you are a hidden talent and rising star. Lastly, it's very important to thank our participants whose presence will boost up the morals and energy of the faculty and as well the organizers. Without you, it's zero. It's a zero. So that much importance you have. My sincere gratitude to you all. And the last word, I cannot complete my speech without talking a little about our upcoming conference. We have this IAP Central Zone Conference, which is going to be held on 1st, 2nd, and 3rd of July. And we have really, for the first time in the history of IAP state, we have 14 very, very interesting workshops with very good faculty. Very shortly, we are going to communicate all those workshops with the details, the program and the faculty. Very, very exciting, very tempting. And I am proud, and our organizing committee is proud to have 20 nationally acclaimed speakers from all over India. They are attending the conference as faculty members. And as well, we have PG PG quiz. We have free papers, e-posters. We have paper presentations. We have debates. We have guest lectures. It's more or less a mini conference academically. And entire one day, that is on 30th, we have dedicated the day, 30th June, for sports activities. I am hopeful that Dr. Sridhar, who is there, who is with us now, right now, is organizing the venue LB Stadium. So I'm sure we will get that and we'll have all kinds of sports activities on that day. Not only that, we have a cultural extravaganza. So please, in nutshell, it's a mini national conference. All of you are requested to attend this conference without fail. So once again, I thank all the faculty members, all the participants, seniors. Thank you, one and all, and wish you all a great learning experience and as well great sharing knowledge. Thank you.
Thank you, Bhaskar sir. Now I'll request Dr. Vijay Kumar, who is with us here on behalf of Central IAP and also from MGM Medical College, Warangal, to say a few words, and then we'll quickly move on to the session. Vijay Kumar sir.
Good morning, Dr. Bhaskar sir, especially for inviting into the TCV workshop, the district hospitals also. As you already mentioned, a lot of work by quantity and quality wise also done, the Department of Pediatrics. And here is a case, previously about 10 years back, when a case of joint pains and fever has come, it was something, and now it is something else even in peripheries. For that reason, this case is being presented. Dr. Padmini has been with me in the first unit, and Dr. Priyanka will present such a case. And one more request through you, sir, for all the people who are now zooming in. Almost every Sunday, at one part or the other part of the state, there will be these 3 workshops, 30 workshops, sir. NCECD, NTEP, or Presidential Action Plan thing. So please, all IAP members utilize these chances. I think I'll stop here, sir. Yes, sir.
Thank you.
Priyanka, all the best.
Sir.
And take this as examination. Don't take this as your examination and present freely.
Thank you, sir. Thank you. Acknowledge the support and guidance of our Central Zone Vice President, Dr. Radhakrishna, sir, and also the other Central IAP EB members, Dr. Srikrishna, sir, Dr. Sri Selam, who are doing an NRP workshop today. We quickly move on to the technical session, but before that, I'll request our guest of honor today, Dr. J.V. Rao, sir, to say a few words first about the PG clinics and his experience of seeing hundreds of postgraduates in a long tenure of more than 25 years. Sir, a few words from you, and then I'll request you to please release the IAP Twin Cities branch journal, issue number 5 for the month of May. Request you to say that it is released, and then I'll show it up on screen. Over to you, sir.
A small correction, around 35 years experience.
No, sir. Sir always looks so young, so I might miss that. I cut 10 years
So
off.
my pleasure, Sri Krishna and
Over to you,
Bhaskar.
sir.
I have high regard and love and affection to both of you. When Bhaskar calls, there is in my dictionary there is nothing like no. He speaks so politely, has been known to me for almost 3 decades. Krishna was not actually my student, but I will be very happy to include the long list of my students. He is like a student for me for all practical purposes. And we were together for UNICEF work in Gandhi when I was heading the department. And he was full of support. Whatever we used to propose, sir, you are there, I am there for you always. Right? Thank you so much, Krishna. And at the outset, let me thank on behalf of myself and Kalyan, the Twin Cities IAP led by Sri Krishna and Bhaskar for taking up this wonderful initiative of having a mock kind of examination wherein the PG will have an experience of facing teachers in a real life scenario kind of thing, where they will present a case and it will be discussed threadbare. And that's a wonderful initiative. It was like a clinical meeting, but of course in a different kind of scenario, like as if it's an exam. I think, let me compliment Vijay and Dr. Padmini for mentoring the student, Dr. Priyanka, for coming forward to present this case. And having said that, the postgraduates and the postgraduates in medical education is changing. Now there is more of focus on even 2019 onwards, the NMC is insisting on a competence-based medical education program. Unlike earlier, where we were a bit more on kind of dialectic, especially for undergraduates. Now there is a group learning, there is a self-learning, and there are tutorials, there are group discussions, and the small group learning, and so much so that slowly the teaching is being focused on developing skills and empowering the student to differentiate between different kinds of case scenarios in a real life situation. And I think in a next year to come, probably the PG medical curriculum also will be modified in such a way that will be totally competence based. Actually, without any such recommendation, the PG curriculum somewhere other training is happening mostly competence based, because they are actually working with us, and they'll be continuously guided by the faculty, and they'll be knowing how to interact, how to deal with an emergency case, and because they'll be posted right from first year on 24-hour night duty along with the senior faculty. And with this, I think we can move ahead. Krishna, I think you can go ahead with the formality of that launch. You can, or should I announce that it will launch? Whatever.
You can
Krishna,
just
over to you.
First, let me share the screens.
First, let me.
So this is the IAP Twin Cities branch journal, issue 5, May 2022. And we have message from the editor-in-chief, Dr. Sanjay, messages from the president and the secretary. And a very interesting journal. The lead article is on heat and health. And we are seeing that this summer is a very important period for children. Many of them get dehydrated and sick. So very key take-home points on what each one of us can do. What are the phases of heat illness? How can we prevent it? How can we treat it? And then we had a symposium on pediatric emergencies, and these are very, very good articles on pediatric emergencies. Dr. VSV Prasad telling us about organizing a small PICU in small and medium-sized hospitals. A lot of experience and insight into how to manage a PICU at a small setup. And Dr. Dinesh Cherla telling us about the latest advances in status epilepticus and refractory seizures, including the latest updates on management of seizures. Then Dr. Suchitra Ranjit, a very well-known pediatric intensivist from Apollo Chennai, who has briefly described the aspects of pediatric trauma. And we have an international speaker as well, Dr. Mahati Reddy from USA, who has told us about pediatric trauma. What are the key aspects related to pediatric trauma? 2 clinical case presentations. One, a child with persistent diarrhea, and this is a case summary of that particular case and key take-home messages from that as well. Very detailed presentation. And another one of a newborn with seizures from Paramita Hospital. The key take-home messages along with the MRI image and what needs to be done, especially for a newborn with prolonged seizures. We had one PG Clinics, Iaptcb Pg Clinics, and this was a very interesting case of an adolescent with fever, cough, and acute breathlessness, which was presented from Paramita Hospital. And then a snapshot of the various events which we've had in the last 1 month. We had a clinical meeting, a physical one at KIMS Cuddles, Kondapur, and then the symposium is, on pediatric emergencies. So this PDF is such that you can click on the link and it will directly take you to the recorded session on YouTube. Then we had the PG Clinics as well, a similar one, and you have the recorded session available here. You can click on it and share this with others as well. We had a Central IAP webinar on pediatric dermatology, and then the big one on NCECD workshop, wherein we had a record number of registrations and very active participants and interactive discussions. And then we end with the flyer of IAP Central Zone Pedicon 2022 with the updated dates of 1st to 3rd July 2022. Thank you. So this is the journal. We'll be sharing it with all the members by email and other digital media. Request you all to please browse through it, share it, and subscribe to our Iaptcb YouTube channel, which has more than 2,200 subscribers right now. Thank you all for the immense support, and even this session will be available on the channel later as well. I now hand it over to Dr. Padmini. Madam, you can just introduce the case for a minute and then hand it over to your postgraduate for presentation. We have Dr. J.V. Rao sir and also Dr. Kalyan available. Over to you all to take the academic session forwards.
Dr. RSV, before that, I request our Dr. J.V. Rao sir to release it officially by saying a few words about that.
Yes, sir, please.
Yeah. My pleasure, Bhaskar and Sri Krishna. With great pleasure, It's my great pleasure and privilege to launch and open up the e-journal of the Indian Academy of Pediatrics, the 5th edition, if I believe.
Yes.
I think every month it is coming up, Sri Krishna.
Every month.
Yes, sir. Yes.
Yeah, this is the 5th one, and that is May 2022 electronically, and it will be available further to all the members to view, and it is very happy. I'm very happy to see that certain very important and relevant topics have been covered in the journal, including the heat and the effect on child health, and how to organize a small PICU in a small center where all facilities may not be existing. Some very relevant topics on emergencies like refractive seizures and all that. I think I congratulate the Iaptcb leaders and request them to continue this initiative of publishing a journal, either if feasible physically or if not feasible even electronically. Thank you so much for the.
Thank you, sir.
Thank you.
I think we can move on.
Yes, sir. Hand it over to Dr. Padmini and then to the presenter, Dr. Priyanka. Over to you both.
Good morning, everyone. Good morning, J.V. Rao sir and Bhaskar sir, Sri Krishna sir, and everyone online. Thank you for this opportunity, sir. A very nice way to start our Sunday with academics. Sir, this child, who's a 12-year-old female child, presented to us with a fever of 4 weeks and joint pains of 4 weeks duration with very vague symptoms. And then we admitted this child and we were working up with this child because the presentation was very vague. And initially we were thinking of so many diagnosis, but then with good history and investigations, the diagnosis we were able to get, and we were able to treat the child and discharge her on time. I ask Dr. Priyanka to present the case.
Thank you, ma'am. Good morning, everyone.
Yeah, Dr. Priyanka, before you start, just like in an examination, we may be stopping you a while because if you note down and at the end of that that particular segment, if you ask questions, that is fine, but that will help you to continue your flow. But in order to make a point then and there itself for the other viewers and for you also, generally in the examination we'll ask you to give a pause at that same moment when we'll ask a query or give a remark and add a suggestion, give a suggestion, add something to it, so that it will be more meaningful. Is it okay for you?
Okay, sir.
And it will be a bit inconvenient for you because you will be stopped. We will be stopping your flow, but it will help you because that is the way examination goes. If you are okay with it, then we can proceed. And Dr. Kalyan, let me say co-teacher. I will not call myself an expert. I would be very happy to call myself as a teacher. So we will be interacting with the presenter as and when required, Kalyan.
Yes, sir.
Is it okay?
Yes, sir. Okay, sir.
Right. Okay.
Good morning, everyone. I'm going to present a case. I'm P. Priyanka. I'm from Kakatiya Medical College, second year junior resident. My guide is Dr. Vijay Kumar sir, professor in KMC, and my moderator is Dr. Padmini Saujanya ma'am, associate professor. A 12-year-old girl, resident of Shamirpet, Warangal district, whose informant being mother is reliable, came to MGM hospital with chief complaints of fever for 4 weeks and joint pains for 4 weeks. The chief complaints are fever for 4 weeks and joint pains for 4 weeks. History of present illness. The child was apparently asymptomatic 4 weeks ago. Then she developed fever, which is insidious in onset, duration of 4 weeks, and which is high grade, intermittent, and associated with chills, but is relieved by medication. There is no diurnal variation of fever. The next chief complaint is joint pains, which is insidious in onset. It is also of duration of 4 weeks. Initially started in the fingers of both hands, then gradually progressed to both elbows and knee joints after 3 weeks. When the pain progresses to the elbows and knees, the pain in the joints of the fingers are still persistent. Joint pain is associated with swelling, restriction of movements, and redness. There is history of early morning stiffness present.
Dr. Priyanka, when you said joint pains progress to elbows and knees and the joints of fingers is still present, what is the importance of that?
There is migratory polyarthritis. Migratory arthritis is not present. When the joint pains are present in the small, when the joint pain progress to elbow, and if it is not present in the previous joints, then it is migratory arthritis. It means in rheumatic fever, we will have migratory polyarthritis.
Do you want to call this as I'll say, let me tell you that you say when you say joint pain, we are only thinking of arthralgia and not arthritis. Am I correct?
First
okay,
initially.
Okay. Anyway, the complaints when you are talking, probably it will be like joint pains only, because that is a complaint from the patient.
Yes.
And whether it is arthritis or not, it is for you to decide.
Yes.
Arthritis or just arthralgia. But as you rightly said, when the joint pain progress to elbows and knees, the pain in the, let me say pain, not pain, pain in joints of fingers is still present. Almost rules out the migratory arthralgia, arthritis, whatever you call it as, which is very typical of the rheumatic illness, like
yes.
the acute rheumatic fever, right?
Yes.
And what is the importance of early morning stiffness?
In inflammatory conditions, there will be early morning stiffness.
Like
rheumatoid.
Most of these conditions are inflammatory conditions only.
Yes. In rheumatoid arthritis, there will be early morning stiffness.
Okay. What are the situations where there is no early morning stiffness?
In rheumatic fever, there will not be any early morning stiffness.
Okay. Will there be in joint involvement in with an infectious cause? Will there be any kind of early morning stiffness?
Yes, sir. Infectious causes also have joint pains.
Will there be early morning stiffness? There is no such. Suppose, for example, a septic arthritis or an osteomyelitis involving the joint. There will not be any early morning stiffness. You know, early morning stiffness generally indicates that it's a chronic joint involvement, and it could be inflammatory, or it could be of a systemic cause. Is it correct?
Yes, sir.
Right?
Yes, sir.
And what is the importance of swelling, redness, restriction of movements of joints?
If it is arthralgia or arthritis, to rule out that, we are asking all that.
How do you rule out?
In arthralgia, there will be only joint pain, sir. But in arthritis, there will be warmth, redness, restriction of movements. Range of movements will be decreased. Then will be swelling.
Okay. And basically, if you want to, thinking that you have examined the child, or you have examined the joint also, what are the 4 points which you will consider when you already told some, which you will consider that it is arthritis and not arthralgia?
As I said, the 4 points will be in arthritis, there will be swelling, there will be decreased range of movements, there will be warmth, and there will be tenderness.
Okay. So let me put it in the other way around. Like there has to be pain on movement or pain on motion, right?
Yes.
There should be restriction of movements also, right?
Yes.
And there should be, when the movement is being taken up, there will be some pain also. Also in association with either heat, means warmth, or erythema. Erythema is one thing which you have missed out. This redness over the joint is one such thing. All need not be there, but there has to be swelling and restriction of movement before we say that it is arthritis. Is it okay?
Yes.
So you would like, from history, you would like to call this simply as arthralgia or arthritis? From the
Arthritis.
history.
Arthritis.
Okay. You can.
Okay. And the mother observed that the child has put on some weight since the last 1 month. And there is a history of hair loss present, and there is a history of lethargy and decreased activity of daily movements. And there is no history of cold intolerance, dry skin, constipation, no history of cold, cough, or throat pain, no history of any trauma, no history of any rash or oral ulcers.
What is the importance of cold intolerance, dry skin, constipation? You wanted to think about endocrine.
As the case is a female child and a history of hair loss present, generally in hypothyroidism there will be cold intolerance, dry skin, and constipation. So to rule out that, I asked.
No, why did you think of this thyroid problem at all? Because do you think thyroid will present with fever and joint pain?
No, sir. In view of put on some weight, for that history, I asked this.
In view of the recent weight.
Recent weight. And no history of cold, cough, throat pain to rule out rheumatic fever.
Okay.
No history of red color urine, no history of loose stools or abdominal pain, no history of muscle pains, no history of loss of appetite, no history of night pains.
Dr. Priyanka, could you elaborate your negative history?
Yes.
Individually
Okay.
from the previous slide?
Okay.
Yes.
So there is no history of cold intolerance, dry skin, and constipation.
Yeah, this is already discussed by Javier.
No history of cold, cough, or throat pain. In a generally rheumatic fever will present with joint pain. So in order to rule out that, the previous history of any throat infection is there. To rule out that, I ask this history, sir. Cold, cough, or throat pain. No history of any trauma. Generally, traumatic arthritis can also present, but it is usually monoarthritis. Just to rule out traumatic arthritis, I asked any history of any trauma. And no history of rash.
Another thing is history, Priyanka, history of 4 weeks. It's unlikely for any trauma to be there with a history of 4 weeks, na? Unless it is an unrecognized trivial injury.
Yes.
Yeah, or partially treated septic arthritis or osteomyelitis, but as this is involving all the many joints,
it is unlikely.
Yeah, unlikely.
Yes. And no history of rash or oral ulcers in a connective tissue disorders like SLE, Behçet's disease will have this. To rule out that, I asked this. No history of red color urine in a HSP, we will have hematuria. To rule out that, I asked this. No history of loose stools, abdominal pain. In inflammatory bowel disease, there will be associated arthritis. So I asked this history. No history of muscle pains. Generally in connective tissue disorders also there will be muscle pains, myalgias. So I asked these histories. No history of loss of
any specific conditions which can present with joint pains or muscle pains and fever?
Fibromyalgia, there will be muscle pains, but no history of fever will be present. So
any other conditions?
Muscle pains.
Muscle pains or muscle weakness?
Proximal muscle weakness will be present in the dermatomyositis, cotton papillus. No history of loss of appetite in view of malignancies, long-standing fever we have to rule out malignancies. No history of night pains. In malignancies, there will be night awakenings due to pain. So I asked this history. Past medical history and treatment history. History of similar complaints in the past 2 months back. Child had fever and joint pains involving both fingers and elbow joint, which was lasted for 1 month. The child consulted in a private hospital and took medication. Then the fever subsided, but there is no improvement of joint pains. Then there is again a 1 month period where she was afebrile, but joint pain still persistent, but she never consulted a doctor in that 1 month. Later, again, she had another consultation in private hospital in view of persistent joint pains and fever. Then she was referred to MGM hospital for further management.
In summary, like how many times this has happened? This 1 month, you're telling twice it has happened. Once it has happened before.
Yes, the
The
last
present is 4 weeks duration.
yes.
Before that, only once this kind of episode happened.
2 months back, she had fever and joint pains.
Only once.
One time. Again,
One
she
time.
was afebrile for 1 month.
Okay. And then she became asymptomatic subsequent to the last episode, or was it was the pain or fever continuing?
Fever subsided, sir, but the pain was not subsided completely, sir. There is decreased intensity of joint pains, but the joint pains never completely subsided.
Yeah. What you mean to say is this history of 4 weeks,
Past
not
history,
exactly 4 weeks.
4 weeks, 8 weeks.
4 weeks, but it was in continuation with the previous episode, wherein there was a combination of fever and joint pain,
Joint
but
pains.
fever subsided, joint pains continued.
Yes.
This time, the pain was of
High
lesser
intensity.
intensity before, and it became more and got associated with fever also.
Yes.
And this is for the last 4 months. Am I correct?
Yes.
Is it so? Right?
Yes, yes, sir.
Okay.
Priyanka, was there any?
This is important. This kind of chronicity and evanescent illness, or say waxing and waning picture is important when you think of probable diagnosis. Right? This is very important point, because this is not a problem which lasted just last 4 weeks. It was there earlier also, and she was not well for quite some time. She got partial recovery, and subsequently she got an exacerbation with symptoms once again. Is a very important point that tells you the whole story, or the whole the natural history of the illness with which she is suffering from.
Yes.
Dr. Priyanka, was there any intake of any other drug NSAIDs for her joint pains
Yes, sir.
throughout this phase which was in she was in this
Yeah.
remission?
Yes, sir. She took some NSAIDs for joint pains and fever. It showed some symptomatic relief for some time, but not subsided completely.
So continuous intake of paracetamol or any NSAID can also mask the symptoms of fever.
Yes.
So even that the treatment history would help you.
Yes. The child has past history of hypothyroidism 6 months back, and she was on thyronam tablet 100 micrograms. Moving to family history, she is born out of non-consanguineous marriage, only single child. There is no history of similar complaints in the family. Antenatal history, she was a firstborn pregnancy, spontaneous conception, registered case, has regular antenatal checkups, immunized with 2 TT injections, iron and folic acid were taken, no history of any blood transfusions or no maternal complications. Birth history, she was a term baby born out of normal vaginal delivery, 2.5 kgs, cried immediately after birth with no NICU admissions. Development history, she attained all milestones as per age, and she is studying 7th. Nutritional history, she takes both vegetarian and non-vegetarian diet. According to 24 hours recall method, she has an energy deficit of 120 kilocalories and protein deficit of 3 grams. Immunization history, she is immunized up to 10 years of age according to National Immunization Schedule, and she didn't take any optional vaccines, HPV. And socioeconomic
Priyanka, her
history.
nutritional history is okay?
Yes, sir. Okay.
Is
Yes.
there any deficit? Oh, 120 is not a big deficit. Okay. Okay.
Socioeconomic history, she belongs to lower middle class according to modified Kupuswamy classification. Summary of the case. A 12-year-old girl born to non-consanguineous parents with history of fever for 4 weeks and of involving small and large joints for 4 weeks, associated with morning stiffness, swelling, restriction of movements, with history of recent gaining weight, hair loss, and with history of hypothyroidism, and with no significant family history.
You said the history of hypothyroidism. How did you conclude that it is hypothyroidism?
She was diagnosed 6 months back.
Okay, that is there in the past history. It is there in the medical history. It is there.
Past
Okay,
medical
I
history.
missed out on that.
Yes.
Do you think the history of the 1 month history of weight, the recent weight gain is because of the thyroid?
Yes.
Does the child have any other features suggestive of hypothyroidism?
Yes, sir. Hair loss is there, sir. Weight gain and hair loss are there, sir, but no other features like constipation, dry skin.
Hair loss can be there because of the primary illness which probably she is suffering from also.
Yes.
And you said the entire history is
totally 8 weeks duration.
I'll call it as 8 weeks. Let us take it as 8 weeks, though it is
4 weeks.
Why that time is important?
Because we have chronic diseases, we have to think of some other diseases. Sir. Acute, we have to think of.
Okay. By definition, most of the books mention what time period as chronic arthritis.
Sir?
As when you say chronic arthritis,
greater than 6 weeks, sir.
It should be greater than
6 weeks.
6 weeks. Okay. And any menstrual history, Priyanka?
She didn't attain her menarche.
She didn't attain. Okay. Was there any excess body hair anywhere else in the body?
No, sir.
What was her sexual maturity?
SMR2.
Coinciding with pre-pubertal. Pre-pubertal?
Stage 2.
Okay. You have mentioned about, in the past history, you have mentioned about hypothyroidism as a...
Yes.
Huh?
Yes.
Because one of our professors was pointing it out with a query that was it the child was diagnosed with hypothyroid. Okay, 6 months back on thyroid now. Okay. From the family point of view, anybody suffering in the family with a similar constellation of symptoms?
No, sir.
There is a query that there is a about rash, but I think you have mentioned that there is no rash.
Yes, sir.
Am I clear?
Yes, sir.
Am I
No
correct?
rash. No rash.
There is no rash.
No rash.
No rash.
There is no rash. There is no rash anywhere in the body, right? And about thyroidism, I think hypothyroidism, child is on the last how many? 6 months back, right?
6 months.
Okay. But you said
Have
the
you mentioned
recent
it?
weight gain 1 month.
Yes, sir. She was not using the tablet regularly.
Complaints was not there.
Not one.
Dr. Priyanka, have you mentioned about the travel history? Any travel history?
No history of any travels.
Is there any importance of travel history with such
Yes,
complaints? Fever
yes.
and joint pain?
Yes. Lyme's disease, endemic areas. People going to endemic areas will have Lyme's disease that also present with the fever and joint pains.
Apart from that?
Apart from that, chronic the chikungunya can also present with fever and joint pains.
I think one faculty was pointing out, Kalyan, that Priyanka, that given the long COVID, the short COVID kind of thing, post-COVID scenarios, was there any history suggestive of
No history.
COVID when Omicron was rampant, it was hitting everybody. She was not having.
She has.
Because everything under the sun, people are describing as a long COVID syndrome. And whether it is linked or whether associated, we really don't know, but it's a possibility. Like it has definitely some long term. And there are some people who had very severe joint pains post-COVID, which lasted almost like 6 months. I don't know about children. I am not very sure about it, but adults.
Yeah. And Dr. Priyanka, what was the type of fever? Whether it was intermittent, continuous?
Intermittent fever, sir.
Intermittent fever. Was it documented?
In hospital, it was documented, sir. Before she consulted outside private hospital, there it was documented, but at home she was not documented.
Okay. So, considering the duration of fever with joint pains, are there any specific type of fevers which presents in such conditions, which gives you clue to diagnosis?
Specific type.
In systemic J, which type of fevers do you usually see?
Fever of high grade with evanescent rash will be this.
Mm-hmm.
And it is a quotidian fever, sir. Rises in every 1 day, one peak at a day.
Good.
In joint pains, Priyanka, as some faculty was suggesting, was there any kind of diurnal variation? Like, is it becoming better over the? You said early morning stiffness.
Yes, sir.
Is it becoming better over the day?
Yes, sir. But it was not completely subsided. But comparative to early morning, there was
Compared to morning, it was better by the day progress. The symptoms became better.
Yes.
About history of rheumatic fever, I think Dr. Subramaniam was raising a doubt that it has to be the antecedent, the sore throat should be there at least 2 weeks prior to illness. That is what I think you have mentioned.
Yes.
You have put as there's no past history
of sore throat
in the recent month or so, 2 weeks, where you had a fever and sore throat and that kind of thing. That should be fine. Kalyan, anything else at this stage?
Sir, we'll continue.
So with this history, Priyanka, what is that which is coming to your mind?
It is, as a duration is greater than 6 weeks, it is unlikely to have any infectious cause, sir. And mostly it should be an inflammatory condition. Either
inflammatory condition of what? Systemic inflammatory condition, or it is a generalized disorder where there is inflammation at multiple organs or multiple places? Or?
It should be systemic, sir.
Why?
Because fever and other features like weight gain, loss of appetite.
Generally, do you expect weight gain or weight loss in a systemic illness?
Weight loss should be this.
Generally,
weight loss should be.
But in this case, probably we are attributing this to the endocrinal abnormality, namely hypothyroid, right? And you said a systemic illness affecting joints, right?
Yes.
And you must be having so many differential diagnoses as of now. From the negative history, what you have mentioned already.
From the negative.
Can you with the negative history, can you shortlist some list of conditions which are possible with this child, considering her age and sex and age and the kind of presentation she had?
As she is a pre-adolescent girl, we can think of SLE.
Think of SLE, yes. One. So what is there for SLE and what is not there?
Actually, there is no history of rash or oral ulcers. What is there is fever and joint pains and hair loss.
Among them, which is more predominantly seen? Among, you said rash and ulcers.
Rash.
Rash is more common?
Rash is more common than oral ulcers.
Rash is more common than oral ulcers. Okay, rash is not there. So that is one thing. Okay. I will say,
Anything else
let me
you
tell
want to
you.
include, Priyanka?
Joint pains, fever with hair loss,
No,
and
not
also
anything.
history of thyroidism, hypothyroid was there. So it may be an autoimmune condition. Most of the SLE will be have other autoimmune conditions can be suspected.
Okay.
Don't straight away go to, sir, sorry to
Why
interrupt you.
No.
Uh,
You can, Dr. Padmini, you can please.
Yes, yes. Don't straight away go to SLE. Think of any other with this history.
No, if
Can you think? Are we
if
thinking
you
of
tell
any other
SLE,
diagnosis?
I will say that
Juvenile idiopathic arthritis can also be
Suspected.
present.
Yes.
if you look at only from the kind of history what you have presented, except maybe hair loss, which could be there in many conditions, weight gain, I'll attribute only to hypothyroidism, which could be a different condition altogether. I will think at the JIA.
Yes, sir. It can also be JA.
I think of JIA as a first possibility. I may not be correct. I may be correct. Like we are talking, you are discussing everything at the level of history only. And okay, what else? JIA, as I let me tell you, JIA is one condition. It could be a dermatomyositis possible.
There is no proximal muscle weakness.
Muscle involvement. Okay.
And got papules should be there. Gotten papules, heliotropic rash should be there. They're not present.
And what should be the minimum duration of the illness to say it as JA?
JIA, it can be, should be greater than 6 weeks.
6 weeks. Yes. So,
if it is systemic onset JIA, it should be, fever should be of greater than 2 weeks.
Okay. Yes.
Reactive arthritis can also be considered, but it mainly involves the lower limb joints. Asymmetrical involvement should be there, and preceding infection of GIT or GUT should be there.
Yeah, reactive arthritis, which is following any viral infection or, for example, any other infection, also can present like that, but it will not be of this long duration. Weeks together, the reactive arthritis generally will not be there. It will be most often it is a self-limiting condition, maybe analysis, this and that could be of some help. Even if you don't treat most of the reactive arthritis, unless they are very, very severe, they subside on their own.
Dr. Priyanka, why can't this be tuberculosis?
Tuberculosis, it should be monoarticular, painless, sir. It is painful. Arthritis is painless and it should be monoarticular.
Yeah. And also the type of the fevers which are mostly seen in the
low grade
rise of temperature and weight loss.
Yes.
And also by 6 to 8 weeks, there will be involvement of other joints also.
Yes.
Can we proceed to examination part, sir? Kalyan, sir?
Yes. JV.
By thinking of all this history, we have differential diagnosis of systemic onset juvenile idiopathic arthritis or systemic lupus erythematosus. Reactive arthritis.
At this stage, you have thought of all these things.
Yes.
Systemic onset JIA, reactive arthritis. Now, what is the presentation of sickle dactylitis, Priyanka? Generally,
sickle dactylitis
you
generally
will have sickle cell anemia, then only you will have dactylitis. Please remember that.
Yes.
So, was there any history which is suggestive of a transfusion?
No history of any transfusions.
The family history suggestive of sickle cell anemia. Is there any history which suggestive of
no.
the symptoms wherein you will have
no history of any blood
chronic history of a transfusion and anemia, a combination of anemia, jaundice, a chronic history of transfusion, family history, and a small joint involvement. Probably that is it. It's fine. Okay, idiopathic, and then you said rheumatic fever. You almost ruled out. But what about rheumatoid arthritis at this age? We'll call it as will it present rheumatoid arthritis?
Generally, juvenile idiopathic arthritis, component of
Sickle crisis generally is a very painful condition. As I was mentioning, that the sickle dactylitis is a very painful, excruciatingly painful condition because it is caused by necrosis following ischemia because of this vessel block.
vaso-occlusive
So it
crisis.
will be very, very severe, and though there is nothing like bigger joints cannot be need not be involved, smaller joints are most often involved because smaller vessels are likely to be vulnerable to be blocked by the sickle cell much more than a larger vessel, which supplies a larger joint.
So, what are the points against malignancy in this case?
Malignancy, there is no night pains, no weight loss, and fever is of high grade. In malignancy, can be low grade fever.
Any other points?
Bone pains are not this. Joint pains are there. Bone pains are not.
Yeah. And apart from that, by 8 weeks almost, cases usually develop this bleeding manifestations also in cases of malignancy. Like petechiae or ecchymosis could have been seen by now.
Weight loss also, right?
Yeah, weight.
Yeah.
Shall I proceed, sir?
Kalyan?
Yes, sir. And also considering the age group, you can decide whether it is into your first two diagnosis.
Yes.
Adolescent, SLE is most common.
In the yeah, Kalyan, continue.
Yes, sir. Yes, sir.
What is the importance of that age and sex mark? And this in this particular case, let us, though there is a, from what you have been describing, there is some clue regarding the diagnosis, but let me tell you, what is the importance of sex and age?
Generally,
Your comment on both the age as well as the sex of the child.
Generally, the systemic onset juvenile arthritis involves both males and female equally, sir. Whereas SLE, female preponderance will be there, and it is almost of in a pre-adolescent girls mainly present 5:1 ratio. And as she is a female child, it can more probably.
Okay. To the as far as the sex is concerned, this particular condition is so common in females that female sex is considered to be the highest risk factor for considered as a predisposing or highest risk factor in terms of score for SLE. When you are considering when you see a patient with unusual symptoms on and off, you always think on and off, and child not recovering with the usual treatment, and the presentation mimicking many other conditions, and especially the illness is evolving over a period of time,
Progressive.
involving different organ systems and different parts of the body. Generally, we consider connective tissue diseases, or otherwise also known as collagen vascular diseases. So I will not, at this stage, I will say only that much, like this is likely to be a connective tissue disorder, considering the age and sex, and also considering the kind of chronic involvement of joints, as well as the systemic symptoms of fever, which is happening for the last 3 months.
Sir, adding to your point, Nelson says 90% of SLE patients are females.
Correct.
And so female gender is the biggest risk factor for SLEs.
Yeah, you are correct, person. So that's what it looks like a chronic illness, probably involving other parts of the body apart from joint, probably. Yes. And at this point of time, let us consider a broad differential diagnosis of a probable case of connective tissue disease. Kalyan, is it okay? Do you agree?
Yes, sir. Yes, sir. We'll continue.
Anything else, Kalyan, before we proceed further?
We'll continue with the examination.
Right. Okay.
General examination. Vitals. The temperature is 98.8 degree Fahrenheit. Pulse rate 88 per minute. Seen in the right radial artery, which is normal in volume and regular in rhythm. BP is 170, about 50th centile according to her BMI. And respiratory rate is 20 per minute. SpO2 is 99 with room air. On physical examination, there is icterus present and some pallor present. There is no cyanosis, no lymphadenopathy, no clumping, no pedal edema. And the head-to-toe examination is normal.
No cyanosis. No
How would you attribute this icterus and pallor to your history?
They didn't notice the icterus, sir. On examination, we saw. Mostly it can be due to any hemolysis. Pallor means anemia should be there and icterus is there. So it should be any hemolysis going on the body.
You said pallor, Priyanka, but when you write in the examination, never say some pallor. It is there, it is there. It is not there, it is not there.
Okay.
There is nothing like mild anemia present. Icterus is there, icterus is there. If pallor is there, pallor is. You commit that it is
Okay.
there. If it is not there, it is not there. Right? So, what is that which is this is a new thing has come up now that there is a history which is definitely suggests as I was mentioning earlier, any patient or for that matter anybody who presents with a combination of jaundice and anemia, especially if it is of chronic duration, you have to consider a background of hemolysis, whatever the cause could be. It could be autoimmune etiology, it could be immune phenomenon, it could be RBC abnormality, it could be hemoglobin, whatever it is. So that is one thing. Apart from that, your blood pressure is 50th percentile. Okay, temperature normal, pulse rate okay, respiratory rate. Head-to-toe examination normal.
Yes, sir.
There is no markers as it
No
is.
markers.
You have a picture of the child by any chance, Priyanka? No?
She didn't cooperate.
Acha.
Actually,
No,
they did not allow us to take a picture of the child.
Yeah, because that is their right. You are absolutely fine. That is their right. That's fine, no problem. Because she is a girl and all that, probably they felt. No, not an issue at all. That's not that important also. And especially if they are not given a consent, there is no problem, no issue at all. Kalyan?
Yes, sir.
Right.
Anthropometry. Her weight is 32 kgs. Height is 134 centimeters. BMI is 17.8, which is normal. And her SMR staging is stage 2.
Priyanka, you said weight gain, but weight seems to be for a 12-year-old girl, 32 and 10 to 50th percentile is.
Mother told history of mother perceived that the child had put on some weight, sir. Actually, there is no recordings of weight, sir.
Okay. When you said head-to-toe examination is normal, did you see the nails and hair?
Yes.
Hair, of course, you said hair loss.
Hair loss.
When we said hair loss, did you see the area where the hair is lost and why
Yes,
that
sir.
is important?
There is no scarring or any.
No scarring. So,
no scarring.
Non-scarring alopecia is one manifestation.
Yes.
Non-scarring alopecia, for the benefit of everyone, is one important point of systemic illness. So their perception is weight loss, weight gain, but it doesn't seem to be like
But
that.
as There is no weight.
What did you feel like looking at the child? Was she looking hypothyroid?
Yes, sir.
How?
There is somewhat distension of the abdomen, sir. And
what about face?
Child looked lethargic, sir, not active as such.
What about face? Was a kind of puffiness kind of thing, fullness?
Face, no features. No.
What about the skin? Dry skin? Nothing?
No, sir.
Cold intolerant?
Considering her socioeconomic status, belonging to lower middle class, she could have been much lower before this recent weight gain, as we can see in the height, which is in between 3rd to 10th centile.
Correct. Probably part of it is hypothyroid. Otherwise, probably our weight would have been much less, because considering, as is rightly pointed out by Dr. Kalyan, height is 3rd to 10th percentile and weight is 10 to 15th percentile. Indicate some recent change. Height generally reflects her development, her growth and nutrition over a period of time. Longer duration, much longer duration compared to weight. Your height will not increase in a short span of time, whereas our weight can increase.
And also the chronic illnesses will affect the height. Next.
Examination of musculoskeletal system. The swelling of all the joints darkened in the picture, that is interphalangeal joints, knees, elbows are present. There is local rise of temperature, tenderness, and palpation present. And there is painful restriction of movements around the involved joints. There is no muscle tenderness, there is no other bony tenderness, and there is no involvement of other joints.
Now you said no other bony tenderness. What means what? No other bony tenderness means?
Apart from these joints, there is no bone pain as such.
Tenderness and palpation over the bone suggest what?
Joints, tenderness over the joints.
No, tenderness on palpation. Tenderness is always on palpation only.
Yes.
Over the bones, not joints. Suggest what?
We need trauma.
Chronic?
Priyanka, understand carefully here. Sir is asking if there is tenderness of the bone.
Malignancy.
What is it suggestive of? Yes.
Right.
ALM. Malignancies.
It's a painful restriction of movements around the involved joints, not around the joint. Painful restriction of movements of the involved joint. Why around the joint? The movement will happen in the joint only. Local rise of temperature and tenderness on Priyanka, probably misspelled. Tenderness on not palpitation. Tenderness on palpation it is. Okay. Right? No, probably it is a typo. Interphalangeal joints, elbow and knee. Looking at the picture,
yes.
Do you think it is a symmetrical involvement, Priyanka?
Yes, sir.
Symmetrical involvement.
Yes.
Does symmetrical involvement has got anything to do with our diagnosis?
Yes, sir.
Yes.
Yes.
Explain how.
In reactive arthritis, there is asymmetrical involvement, sir. Whereas in SLE, there will be symmetrical involvement, and in psoriatic also there will be asymmetrical involvement.
In trauma also it will be asymmetrical. Infectious joint involvement like septic arthritis, osteomyelitis is also asymmetrical. What about JIA?
JIA, it can be symmetrical or asymmetrical.
It can be depending on whether it is a monoarticular or a poly. If it is monoarticular kind of thing, there is no possibility, not much of possibility of asymmetrical involvement. So it could be asymmetrical, it could be symmetrical also.
And also another point, usually this local rise of temperature and tenderness will be seen in even in JA, SLE or malignancy and infections, but the intensity of joint pains or tenderness will be more in the malignancy and infection when compared to all the rheumatological illnesses.
Yes, that's a valid point what Kalyan is raising, that the tenderness is a much pain and tenderness as it is are much more severe in malignancies and infections, infection being an acute condition. And any rheumatological condition, broadly speaking, the pain in general is not much of, except there are certain conditions where you have pain as a basic condition in a rheumatological illness. Like there are certain conditions like fibromyalgia, where there is it's considered as a pain syndrome, where you have a debilitating joint pain and a very severe joint pain, and you'll have a normal clinical examination, normal lab, and everything being normal. There will be a very poor sleep pattern, and child will be having a very severe debilitating pain, because that could be especially this also happening in an adolescent, female or male adolescent, and more so this also is more common in female. The condition is known as a fibromyalgia in a child. Yes.
Next. Then no deformities of the spine noted. Systemic
So
exam.
was there one minute? Was there any deformities in the involved?
No deformities noted in the joints, involved joints. There is no deformity.
No deformity.
Systemic examination.
Yeah, have you followed any assessment criteria considering JA as a differential diagnosis while examining musculoskeletal system?
Actually, we should look for pediatric gait, arms, and spine. But I asked 3 questions, in that only 2 questions positive, but I didn't examine all the manuals.
Yeah, it should have been done, because considering the history and the one of the main differentials is JA, so PGL should have been assessed. Fine. Continue.
Systemic examination, CVS system, S1 has to heard, no murmur. Apex beat is heard at 5th intercostal space on the midclavicular line, neither heaving nor tapping. Respiratory system, trachea central, respiratory movements are symmetrical, no chest retractions, no dullness on percussion, bilateral equilibrium present, vesicular breath sounds heard all over the lung, and no adventitious sounds heard. Abdomen soft, not distended, no tenderness, liver, spleen are not palpable, bowel sounds are heard normal, no other mass is palpable. CNS examination, higher mental functions normal, no focal neurological deficits, cranial nerve examination normal, motor system normal, sensory system normal. Summary. A 12-year-old girl born to non-consanguineous parents with history of fever for 4 weeks, small and large joints involved for almost 8 weeks, associated with morning stiffness, restriction of movements, swelling, with history of recent gain in weight, hair loss, with history of hypothyroidism, but with no significant family history or no blood transfusions in the family. And examination, she has found to have polyarthritis with restricted range of movements of both small and large joints.
So now post examination, so what would be your differentials in diagnosis?
As there is icterus pallor, some hemolytic condition is going on, and associated with the fever and joint pain for more than 6 weeks, it could be, and female child, pre-adolescent girl. Possibly it can be SLE, as there is no lymphadenopathy, no hepatosplenomegaly, or no evanescent rash. It can unlikely be systemic onset JI.
Okay. So any other points favoring JA?
Fever and joint pains, and
Fever and joint pain. But in systemic onset JA, fever will be the predominant symptom. Yeah, but in other types of JA, it would be the joint involvement. Have you done any eye examination?
Yes, sir. After examination done, normal.
What is the importance of that?
Eye.
Priyanka?
And uveitis, we should look for uveitis, sir.
Look for, how do you look? What is that you look for uveitis? That is for the benefit of everyone, say what is uveitis and what is that you look for?
We should look with slit lamps.
In uveitis, you need a slit lamp for everything. You will have a red eye like any other condition. There will be a redness. There could be some amount of pain, which is complained by the thing. And of course, you want to see the flare and all that. What you call the ophthalmologists basically call it as a flare. Then you need definitely the lamp, but
And also the irregular pupil.
yeah, once it gets healed, in the process there will be some scarring, and then it will lead to irregular shape and size of the pupil also.
Shape and size.
Any other organ systems examination is important?
GIT hepatosplenomegaly.
Why hepatosplenomegaly is important?
Sir?
Why hepatosplenomegaly? What way it is relevant?
If it is any hemolytic anemia, we should look for splenomegaly.
Are we ruling out by saying there is no any diagnosis by saying there is no hepatosplenomegaly? That's what sir wants to ask you, Priyanka.
Yes, ma'am. We are ruling out a systemic onset.
Anything else?
Hemolytic anemia.
Associated with bone pains and
Bone pain.
splenomegaly.
Malignancies.
Yes.
So, any other conditions which presents with fever, bilateral uveitis, and joint pains?
Yes, sir. Behcet's and Ritter syndrome.
You examine the mouth and nose, Priyanka?
Yes, sir. For oral ulcers, I looked for mouth, hard palate, I looked.
The nose?
Nose, there is no mucosal bleeds.
You examine for mucosal bleed. Nothing else? You don't see any nasal ulcers in these group of conditions, Priyanka? You have a possibility of a septal ulcer, which is a painless ulcer involving the nasal septum. Okay?
Okay. Thank you.
Kalyan,
Yes, sir.
I want to ask, I want you to ask her some more questions.
So, what would be the, the main differentials now?
Main differentials, it can be juvenile idiopathic arthritis or SL.
Or SLA. So, have you seen on the examination part, have you seen any rash on the trunk?
Yes, no rash.
No rash.
No.
And
even in
SLE
history, they were not giving any history of rash, sir. Yes, we probed the mother also, but never there was any history of rash.
Yeah, but in systemic onset JA, the rash would be more prominent only during the febrile illness.
Yes, evanescent rash, salmon.
Yeah, yes, exactly. And also during that high grade fever, particularly on the trunk and the face. So until and unless in some cases, if we see the trunk during the high grade fevers only, we'd be appreciating the rash. And the other point which is against SLE is there is no rash at all. Either
The
in the
rash
history
is
or
present
the,
only in 40 to 50%.
exactly. And also the absence of oral ulcers.
Pepe.
Then sir, we'll continue with the
I think more likely J. Kalyan, are you satisfied with the differentials what she mentioned after examination?
Yes, sir.
Okay. Dr. Saujanya, should we move ahead, or you have anything to add at this stage?
No, sir, we'll move ahead.
Investigations. Hemogram. The hemogram was done on different occasions. There was anemia present. It is almost 7.7. There is no lymphocytosis and there is no thrombocytopenia.
So you're talking about lymphocytosis.
Leukocytosis.
Leukocytosis or leukopenia. There is no leukocytosis or leukopenia.
It would suggest what? Leukopenia.
Leukopenia is generally present in SLE, but leukocytosis will be present in any malignancies.
And acute
infections.
And you said leukopenia.
So,
in leukopenia, what is more specific about
lymphocytes.
Lymphocytes. Yeah, lymphopenia is supposed to be very, very prominent and one important clue towards that particular diagnosis, if you are entertaining that entity. This anemia of 8.8, 7.7 and kind of thing, what is the kind of anemia? It was like microhypo or normocytic normochromic?
Smear microcytic hypochromics.
Suppose if it is hemolytic anemia, you are thinking we have considered hemolytic anemia as a possibility because of anemia and jaundice. Microhypo, does it go along with that?
It can be present, microcytic.
Microhypo with hemolysis, what are the conditions?
Thalassemia Minor.
That's all.
Sickle cell also, we can have sickle cells with microcytic.
But sickle cell is the basic morphology itself is different. You will have a sickle which is available on the peripheral smear. It is not available on a sickling preparation.
Yes.
And it is a morphologically a different kind of RBC it is.
Yes.
Anything Kalyan at this stage?
Next we'll see the ESR and CRP.
Okay.
Routine RBS was done 7.6 and CRP ESR were done on two different occasions. It was raised. Initially it was 51, next latter 45. ESR was 40 and 30.
Considering the ESR, CRP and raised platelet, this is favoring more towards the systemic JA.
So platelets were not raised, sir, almost within the normal range.
So,
what is
the previous plate? 5 lakh. 4.9.
4.5. That 4.95 is one thing which is generally 1.5 to 4 lakhs, no? 4.43 a bit higher side. 4.95 is definitely on the higher side. 3.8 is in the normal limits.
As his routine CU was done, albumin 1 plus, RBCs 1 to 2, first cells were 2, bile cells and bile pigments present. Blood urea and creatinine were normal. The LFT was done, TSB showing 2.1, and enzymes were normal. Chest X-ray and ultrasound abdomen were normal, ECG were done normal. When thyroid profile were done, before starting treatment, it was where she was diagnosed to have a hypothyroidism. Then it was TSH was 18.3. After starting treatment, she has a TSH of 0.45 and T3 of 0.92 and T4 of 11.6. Whereas TPO antibodies were raised to greater than 1,000.
Suggesting?
This is probably due to an autoimmune condition. Autoimmune thyroiditis.
Autoimmune thyroid, do you mean it is that kind of autoimmune thyroiditis, which is also common at that age? Is it a part and parcel of the disease, or is it a separate entity?
Separate entity.
It can be separate entities, or it will be associated with SL.
Can be.
It can be
also.
Can be also. In view of all these suspecting features, either it can be systemic onset JA or it can be SLE, as there is no feature suggesting of hepatosplenomegaly, Vancomycin, Rash, or other. We have to rule out SLE. So first initial screening of ANA was done, which showed titers of greater than 1:80. Then ANA screen was positive, and then we sent the profile, which showed anti-dsDNA positive and anti-Smith positive, which are specific for SLE.
Okay, what is the importance of positivity of ANA alone?
ANA alone is a screening test, sir. It can be present in almost 90% of the people, but the specificity of antibodies should be considered.
Yeah, the problem with ANA is even if it is present in 20% of otherwise normal individuals also.
Yes, sir. Yes.
And it is, as you rightly mentioned, it is a kind of generic information it gives regarding the presence of antibodies towards its own, towards the patient's own cellular nuclei component, and doesn't clearly indicate what is the exact disease with which the child is suffering from. And your comments on anti-dsDNA, ma?
Anti-dsDNA is more specific for SLE, sir, and it indicates the disease activity. Progression of disease can be seen by anti-dsDNA.
Even your ANA also, even if it is not much of a diagnostic value, it has got a prognostic value in the sense when you examine, you may not be able to do a anti-dsDNA, which is a bit more costly than ANA.
Yes.
And practically speaking, it is better for us to do an ANA and see whether the child is responding or not on a periodic basis. So even
Yes,
not
sir,
for a diagnostic purpose,
ANA usually it correlates with the disease activity, sir. When we diagnose it to be a case of SLA, with the anti-dsDNA being positive, ANA also it correlates with the disease activity, especially in nephritis.
No, that is what I am telling. So
as such, ANA alone does not have any specific
diagnostic significance.
Yes, sir.
Yeah, and also ANA should be done only by immunofluorescence method.
Yes.
Instead of the ELISA.
ELISA.
Yeah, they did this as a
yes, sir, immunofluorescence. Yes, sir.
This was done in an outside lab, Dr. Padmini?
Yes, sir.
Not in our
NGM.
Okay.
And the direct Coombs test was done.
What is the importance of that?
Any autoimmune hemolytic anemia.
Autoimmune hemolytic anemia. Present or absent?
Presence, direct test positive. Sickling test was done, negative. To rule out rheumatic fever, ASO titers were also sent, which were negative. The rheumatoid factor was negative.
What is the importance of rheumatoid factor? Doing a rheumatoid factor?
JAA, it can be due to RF factor positive JAA and RF factor negative.
Priyanka, how many percentage of JAA are rheumatoid factor positive, seropositive? Tell me. Not even 10%, 10 to maximum 20%. So rheumatoid factor, though it is routinely done, is not of much significance because very, very small number of children with JAA are rheumatoid factor. Most often children with JAA have a seronegative or rheumatoid factor negative arthritis.
But in adults, it is the other way. Almost 85 to 90% is positive RF factor, but in pediatrics, as sir said, it is hardly 5 to 10%.
Genetic count was 5%. And we have considered the ACR and Euro criteria for diagnosis.
Which is more recent, Priyanka, among these. ACR is of 90s, 95 or sometime. And EULAR criteria are of recent. Though they mention that these criteria are not for clinical use and basically for a clinical trial use, they practically have definite utility in the absence of any other criteria which are purely of clinical nature, and most of these things are very relevant also.
Yes. In that, there will be clinical criteria and immunological criteria, sir.
Yeah, I would like all the PGs to have a very clear look at these criteria, which are very important for you. Please note down. They are available in most of the textbooks also, but have concentrate on these things because these are the when you say criteria or the scoring system, it obviously means that these are the systems and these are the findings you need to look if you are to suspect a child with a rheumatological disease. Because most often with a different kind of varied presentation, a diverse kind of clinical and evolving clinical symptomatology and evolving involvement, and no clear-cut picture, it most often we have to suspect these disorders than say confirm and say, look at this child is having 100% features. And as I was mentioning, neurologic, in fact, that should have been a Priyanka, that should be a neuropsychiatric component is much more predominant.
Neuropsychiatric.
Though probably I don't know about scoring, but you will say books describe more psychiatric involvement than the neurological involvement as it is.
Especially in adolescents, sir.
Yes. And it is also important that there is a depression which is described along with these disorders.
Yes.
A clinical kind of a significant depressive element. And books mention that it is very difficult unless you clearly evaluate. This depression is because that is coincidentally happening in an adolescent child with other problems, or is it related only to this disorder is one difficult thing to assess. That's what books mention.
And in complications also, the neuropsychiatric disease is given as one of the most predominant complications, sir.
You were talking about rash, Priyanka.
Sir.
Though in this particular case there is no rash, right?
Yes.
But if rash is there, just describe for academic purpose. Just describe what kind of rash you will have. What kind of different kinds of rashes you have.
Normally there will be macular, macropapillar, vesicular, these squamatic rashes, but initially there will be rash in the macular rash over the prominences and the nasal
region.
bridge. Malar prominences and nasal bridge with sparing of nasolabial fold.
Yeah, sparing of nasolabial fold is described as a important cutaneous manifestation. A raised non-pruritic rash and also non-scarring rash with involvement of bridge of the nose. Sparing of the nasolabial fold is described as one of the important kind of major manifestation of a especially cutaneous manifestation. Others could be a vasculitis, a purpura, or you can have a cutaneous lupus, or rarely you may also have a discoid lesion, a discoid lupus, which are uncommon relatively. Yes.
So ACR and Euler criteria should be fulfilled only if ANA screening should be positive. Then only we have to look for this criteria. If ANA screening is negative, we shouldn't look for this criteria.
You need
ANA screening positive with the titers greater than 1:80, then you go for clinical criteria. That is constitutional. We have fever, which have score of 2. And cutaneous, it will be non-scarring alopecia, oral ulcers, subacute cutaneous or discoid lupus, acute cutaneous lupus. There will be each scoring in this. If we have many features in cutaneous itself, then we have to take the largest criteria as only one criteria. We shouldn't take all the criteria into score. And arthritis, there should be synovitis or tenderness in greater than or equal to 2 joints, 30 minutes of early morning stiffness, which is having a score of 6. And neuropsychiatric features like delirium, psychosis, and seizures. And serositis, pleural or pericardial effusion, acute pericarditis, and hematological features like leukopenia, thrombocytopenia, autoimmune hemolysis, and renal like proteinuria greater than 0.5 gram per 24 hours, or class 2 or class 5 lupus nephritis, class 3 or class 4 lupus nephritis. And there will be immunological criteria, that is antiphospholipid antibodies, low complement levels, and highly specific antibodies like anti-dsDNA and anti-SMID DNA. Here I am getting a score of 20. At least 10 points should be required for diagnosis.
Yeah, your 2 investigations themselves I have given you 12. So the remaining you need only another 8 only. Okay. Kalyan?
Yes, sir. Well, you have not done this complement levels?
Yes, sir, done, sir. Complement C3 was 8 less, sir, but C4 is normal only. I have new put in.
Okay.
What is the importance of antiphospholipid antibody, Priyanka?
There will be like antiphospholipid antibody in pregnant women. There will be loss of pregnancy, sir. So we have to look for APLA syndrome, recurrent losses.
Abortion.
Venous thrombosis will be there.
Exactly.
And we have another criteria, that is sleep criteria, which is not specific. It also has a clinical criteria and immunological criteria. At least 4 of the criteria should be fulfilled to have diagnosis.
There are only criteria, whether present or absent. There is no right.
Yes. So based on all these features, I conclude as it is any screening positive with the fitting of Euler criteria greater than 10. I would like to diagnose this as systemic lupus erythematosus with autoimmune thyroiditis as TPO antibodies are greater than 1000.
Yeah.
Okay.
So
now management.
Yeah.
How we manage this case as any screening and Euler criteria positive, and the child didn't have any features of nephritis or complicated severe SLE. So we just manage with mild mild SLE with the hydroxychloroquine, prednisolone, naproxen, and thironone. Child started improving after 2 days of steroid therapy, and the fever, joint pain, swelling subsided. The child was successfully discharged, and the child is regularly followed for optical examination, blood pressure, weight monitoring, and CUV monitoring.
Go back to the previous slide, Priyanka.
Yes.
You said these drugs, but how long you are going to give them? Of course, Tylenol is different. How long you are going to give them?
Hydroxychloroquine should be used for almost a continuous therapy, sir, months to decrease the flare-ups of SLE. Prednisolone we can taper in 3 to 6 months. Naproxen for pain we can continue as the symptoms subside. Thyronorm we have to continue it.
Could you explain each function of the individual drug?
Hydroxychloroquine,
Where does it act?
Hydroxychloroquine is an anti-malarial drug, sir. So it decreases the flare-ups. And prednisolone, it decreases the fever. Anti-inflammatory action will be there. So
Steroid has an anti-inflammatory action.
Yes.
But HCQs are given for a longer term,
Longer duration.
as you cannot continue prednisolone for longer periods of time, as it has its own side effects such as increase in the glucose levels or the hypertension or the hyperlipidemia, obesity, and all these things. Usually HCQs act on the T cells and cytokines. So
and HCQ also has a side effect of retinal toxicity. It should not be given more than 400 mg.
Yeah. So is any regular follow-up required while a patient is on HCQ?
Yes, sir.
To look for?
Ophthalmic examination for
retina.
Retina? Eye?
Eye retinal toxicity is present.
And NSAIDs for how long?
Mostly for months to decrease the pain, symptomatic relief is achieved.
Reduce the inflammation, pain, and also fever.
Yes.
So this, as you said,
you can adjust the dose to a dose which is giving reasonable relief of symptoms and then continue for over a period of time. You need not give the maximum dose or whatever it is. For an individual patient, if somebody is is happy with an approximation of X milligram, and then you don't have to give an optimal dose, you can continue the same dose for a period of time. Because naproxen also is not a simple drug. It also causes a lot of adverse
side effects.
And as you said, it is divided into whether there is any organ involvement or if there is any major organ involvement or no organ involvement, and then treatment is decided. So if there is any other organ involvement, major organs getting involved, would you like to add any other drugs?
Yes, methotrexate can be given.
Methotrexate.
And azathioprine,
exactly.
Cyclophosphamide. If it is severe SLE with nephritis is there, we can use cyclophosphamide.
Especially if there is nephritis.
Yeah. Apart from this treatment part, would you advise them any other precautionary measures?
Photosensitivity, they should go to sun. Photosensitive rash will be there, and
avoidance of sun exposure.
Avoidance exposures.
And application of sunscreen.
Sunscreen to go out. And apart from that, supplementation with the vitamins.
Yes.
Particularly
antioxidants and vitamins.
So, are there any newer monoclonal antibodies which are tried in SLE? Yeah.
One?
Rituximab also can be given.
Rituximab, infliximab.
Belimumab is the one which is showing encouraging results. So as this is an evolving disease, at present when the child is diagnosed, he may be having no major systems involved. But as you have mentioned in your next slide, a regular follow-up of all the frequency of around 3 to 6 months depending on their symptoms, it has to be assessed and then started on the
regular cardiovascular examination also is of importance.
Yes,
and bone densitometry should also be measured frequently.
Steroids.
Yeah.
osteoporosis.
And in between, there are flare-ups also. She may require steroid. So it's yearly. Once it's better to get the child bones densitometry done.
Leon,
Yes,
we
sir.
are coming close to our time, and we need to give some time for the mentor to interact also.
Sure, sir.
Good job, Priyanka. You
Thank
did
you,
a
sir.
reasonably good job. But
Good
your
presentation.
scope for improvement also. But since you are next year exam going, Priyanka, you are
Yes, sir. Next year. Next year.
next, I think October you will finishing your
Yes.
course. So work hard. Good presentation, and Dr. Okay, Dr. Padmini.
Sir.
I want you to interact or give your remarks, or you have anything to share with us regarding this case, or in general about this particular disease, once, because it's now almost a confirmed diagnosis.
Yes, sir.
You can proceed so that we can hand over to the moderators once you finish that.
Okay, sir. Thank you, Priyanka, for a good presentation. Thank you, J.V. Rao sir and Kalyan sir for such an elaborate and patient discussion. You have left us with no points to be discussed, sir. Everything, almost everything is discussed here. And this, coming to this case, this 12-year-old female child presented to us with very vague symptoms of fever of 4 weeks and joint pains of 4 weeks, sir. And earlier, with the history, like you rightly said, we were thinking of systemic onset JIA and SLE, and as a third diagnosis, we have put even reactive arthritis also. So there was no, though there was no relevant history, but as we proceeded with investigations, the diagnosis narrowed down to SLE, and we could diagnose SLE within a short duration of time in this child, though the symptoms and presentation was very vague. The mother was giving very nice history, sir. And then we started the child on, as Priyanka told, steroids and HCQ, and she dramatically responded because this child was suffering a lot with joint pains and fever, sir. And in fact, for a few days, she was even refusing to visit the washroom also because of the joint pains and restricted movements. But within 2 days, there was dramatic response with the treatment, sir. And the mother was very happy seeing the response in the child. And we discharged the child with the HCQ and some multivitamins and steroids, and we put her on regular follow-ups now. And few points about
please.
SLE, yes, sir. And SLE, this disease is a chronic autoimmune disease with multi-system involvement with circulating antibodies against its own antigens, especially nucleic acids, sir. And antibodies to dsDNA can form immune complexes, and it can be deposited in various organs. Almost all the organs it affects, sir. It's a multi-organ involvement. And initially, the child might present with fever, rash, malaise, and arthralgias. But as the disease progresses, the child can present with the multi-system involvement. Like in heart, it can be pericarditis, myocarditis, and in CNS, it can be seizures, stroke-like symptoms, and neuropsychiatry symptoms, behavioral abnormalities, and depression. And in joints, there can be restricted movements, joint pains, arthralgias, and proceeding to arthritis also, sir. And then coming to diagnosis part, we have done the same things here again, anti-DNA and anti-dsDNA. Anti-DNA is not very specific though, because it, as J.V. Rao sir rightly mentioned, it can be positive in normal individuals also, 30 to 40% of them. But it can be useful as a screening tool and look at the disease activity, especially in nephritis. And anti-dsDNA and anti-Smith is more specific for SLE, sir. And when antihistone antibodies are present, it can be pointing towards drug-induced lupus. And then once it is diagnosed, we have to act fast. And these children have to be put on NSAIDs like naproxen to relieve them of the joint pains. and steroids have to be started. And steroids, as they have their own side effects, and they can cause hypertension, hyperglycemia, and necrosis of the head of femur and hypertension. The dose of steroid has to be adjusted, and it has to be withdrawn as early as possible once the child is symptom free, sir. And there are some other steroid sparing immunosuppressive agents like methotrexate. Once the child is not tolerating steroids anymore, or the complications have developed, we can switch to these steroid sparing immunosuppressive agents like methotrexate, azathioprine, mycophenolate mofetil, and cyclophosphamide, sir. Cyclophosphamide, especially in severe disease, it is very much helpful, but the side effects are hemorrhagic cystitis and gonadal failure. But in adolescents, gonadal failure is not very much. Complications, so the child has to be kept on regular follow-up to look for complications of the disease and also complications of the treatment, sir. Right, like Priyanka has mentioned, we have to put the child on regular follow-up and look for eye examinations, look at the heart of the child, the kidney function of the child, and how the child is regarding how the child's growth is proceeding. And regarding the complications, mostly long-term complications are premature atherosclerosis and malignancy, sir. And in short term, we will see neuropsychiatric and glomerulonephritis mostly. Almost all the organs are affected, but predominantly these are the complications that we see. And coming to the prognosis, with advanced treatment and good approach and multidisciplinary approach, the 5-year survival rate is almost more than 90%, sir. And thank you very much, sir, for a very elaborate and patient discussion of the case. I think it is benefiting all of us.
Yeah, thank you.
And I personally want to thank Dr. Vijay Kumar, sir, our unit chief, for giving me and Priyanka this opportunity to a part of this discussion today.
Thank you
and
very
IAPTCB,
much.
IAPTCB also to allow us to participate in this discussion. Thank you very much, sir. Dr. Bhaskar, sir, and Sri Krishna, sir, thank you very much.
Anyway, I congratulate and compliment the presenter, Dr. Priyanka, the faculty who mentored her, Dr. Padmini Saujanya, Associate Professor, JMC Warangal, and of course the team leader, Dr. Vijay, who we have a long attached, long-standing friendship and association. I compliment the entire department for presenting such a nice case, good case, which is a multi-system involvement. With this, I think I'll hand over, and before I hand over, I would like to thank on behalf of myself and Kalyan, IAPTCB, for giving the opportunity to be on this platform to share whatever experience and whatever knowledge we have got on this case discussion. I thank each one of you, the participants, and the PTCB for giving us the opportunity. I thought when they gave 2 hours, I thought 2 hours, can we really, will we be able to spend that much time on a single case? But time just flew off just like that. Now it's exactly almost 11 o'clock. We are on time exactly. Once again, thank each one of you, and hand over the proceedings to Dr. Krishna and Dr. Bhaskar. Thank you.
Thank you, sir. Thank you.
Sir, a small word.
Yeah, please, Dr. Kalyan.
Yeah, I would like to thank IAPTCB and thank you for giving me the invitation, sir, and also encouraging youngsters like me. And my special thanks to Bhaskar sir and Sri Krishna sir. And it was a good presentation by Dr. Priyanka, and also well moderated by Dr. Padmini ma'am. So even I thought, sir, Jayavira sir, even I thought when Sri Krishna sir told me about the presentation would be of around 1.5 hours, I thought whether we could extend it for around 1.5 hours. But as we have started this, so it's almost 2 hours now. Then, sir, thank you for giving me the opportunity, sir.
Yeah, it's vice versa. Actually, we should be thankful to Dr. J. Rao sir and to Dr. Kalyan because your wisdom, knowledge, which had really helped all the participants a lot. And it was a really good presentation by Dr. Priyanka. She is a second-year postgraduate student, presented so confidently, and nowhere she did a mistake, to the best of my knowledge. And I'm really grateful to the faculty, the way you had questioned, commented, and give valuable tips to her, to all the participants through Dr. Priyanka. That is the essence of the experience of Dr. J. Rao and the essence of the Bright Stars upcoming Dr. Kalyan. We had thoroughly enjoyed. It was almost 95 minutes purely academic discussion, which was closely followed by around 50 participants on this webinar. And I'm sure must be more than 100, 150 on YouTube. And this YouTube recording is available from right now until 1 year. It would be, it's already there in the link, which we had forwarded to you, Zoom link and YouTube link. So this can be seen by the participants. And special thanks to Dr. Padmini and Dr. Vijay Kumar for forwarding this case, for presenting this case to TCB. And special thanks to the participants who had interacted so well. And me personally, I had really thoroughly enjoyed and learned a lot. I became more wiser after listening to you people. I knew little, but I learned a lot now. So I request Dr. Padmini and Dr. Priyanka to send the abstract of this entire presentation. This would be published in our Iaptcb June journal. So with this few remarks, on behalf of entire IAP Twin Cities branch executive board and members, we are thankful to you. Thank you very much, sir. Good day, sir. Enjoy.
Thank
Enjoy your Sunday.
you, sir.
Thank you,
Thank
sir.
you so much.
Thank you, sir.
Thank you so much.
Thank you.
Kalyan, thank you.
Thank you, sir.
Meet sometime, Kalyan.
Sure, sir. Sure.
Now we'll bring Dr.
sometime.
Kalyan to the forefront, sir.
Okay.